And then I just heard that the osteoporosis one is giving trouble loading. We weren't doing that one today anyway. Because really you might have a headache after we're done with this. And I know y'all are tired. Did I have any exams this morning?
Yes, ma'am.
Yeah?
Yes.
All right, we go.
It's good.
Okay. Hey, I just teach the class, okay? Well, I'm going to testing committee tomorrow. I'll let y'all know how it goes, what comes back. Don't do me like that. I'm trying, okay? It seems like the more I try to direct, the worse we just go in the opposite way. So I was like, maybe if I just give y'all everything, and then we'll do good again. But we're going to keep going. It's be all right. Okay, so when we look at headaches, we say headache, but there are several different kinds of headaches. I will just give you the treatment of how you're going to treat each of these headaches, and then you will learn more about each of the headaches later. So if you have an exam question that's giving you all of these symptoms that are typical of a headache, I'm not going to make you diagnose. It is just there for the completeness of the way that I write the questions and that we're supposed to write the question. And it's going to be like, they have this headache, what do you treat them with, okay? So when you're going through this, the way that I would try to study for this is making each headache that you have, and then what are your treatment options that you have for those headaches, that type of headache, okay? So, what is my headache that I'm treating, and then what are my meds that I can use to treat those particular headaches? ELOs, same things that we typically talk about, so make sure you're looking at your mechanisms, all of those great things. When we're looking at the classifications of headaches, we have, again, our different types. Well, we have our primaries. Those are the ones that you saw on that intro slide. So a migraine, tension, or a cluster headache are usually the top three that we're talking about. But you do have secondary headaches that are usually, bless you, happening because something else is going on. You have to then go and figure out what that something else is, okay? So we call it snooping. You have to kind of go around and figure out what is actually causing this person to continuously have these headaches. A lot of the times when you're treating headaches, it's going to require a diary from that patient to kind of see, hey, are there certain foods that I'm eating? Are there certain situations that I'm in that are causing these headaches? Like, what is causing my headache? And if I can't avoid it, then I'm going to avoid it. And a lot of times we don't know what that is unless we kind of like document what's happening when they start to have these increases in the headache. So all I want you to know is that, again, there are 3 headaches, okay? We will talk about the headaches. I will tell you what the headaches are. You will see that with some of your treatment, sometimes you'll hear if they have aura versus if they don't have aura, and that's specifically looking at your migraine headaches. So with aura, like sometimes people will say like, oh, I'm starting to feel nauseous, or oh, like my vision is starting to get blurry. Some people will actually throw up before they start to actually have their migraine. And then you're without aura, okay? So different ways that your patient can present, and sometimes we will approach our treatment a little bit different depending on what we're looking at. So another breakdown, what I want you to know here, again, migraine headache, tension headache, cluster headache. When you see acute, anytime you think of acute, that is us saying I am aborting an actual headache that this person is having, okay? So acute treatment, like on the spot, I need to treat them right now, so that is abortive therapy, okay? So you can do acute/abortive because you can see this said either way. And then your prophylactic treatment is, I've had so many headaches a month and I don't want to have that headache anymore. Is there any type of prophylactic treatment that you can give me to prevent me from having that headache, okay? So just like we always talk about prophylaxis, our prophylaxis is preventative. That is something that we're going to put our patient on, and they would take it every single day to prevent them from having a migraine, okay? So acute is abortive. I'm stopping the headache that I have. I have a migraine right now. I need some medication. You're going to treat me with an acute medication or an abortive medication, not give me a prophylactic one, okay? So when you look at this, again, we said we're breaking it into our 3 different types of headaches, and then just like you see on this chart, you can say, all right, what are my acute options? What are my prophylactic options? Tension headache, what are my acute options? What are my prophylactic options? Most of our lecture is going to be about our migraine headaches. So several people have different types of triggers. Important for you to figure out what trigger you may have, right? So there's some things that we can do where we avoid those triggers, right? I can avoid certain drinks. I can avoid certain activities. But there are some things like y'all being here, right? This can be a stressful situation for you, but you can't avoid it if you want to finish the program, right? So you can continue to, in certain situations, have those migraines, certain situations that are stressful to you that you can't remove yourself from. Sometimes we'll see people who may have trouble or issues in their relationships, right? And if they don't want to walk away from that relationship, or if they can't walk away from the relationship, that could be that repetitive trigger that continues to happen to them. So you trying to figure out what that trigger is important, because if it's something that we can eliminate, we eliminate it. If not, then that may be where that patient ends up on some type of prophylactic treatment to kind of help them manage that situation until they're out of it, if they ever get out of it, right? So just make sure that you're thinking about your triggers, because yes, we have medications. Do we love to just put our patients on medications and leave them there? No, okay? Okay, so acute treatment. If I said acute, is the same thing as saying what? Abortive. I'm stopping a headache that this patient may have. What we're, bless you, trying to do in this situation is make our patient comfortable again. Depending on how bad their headache is, and this one we're specifically talking about our migraines, there are some people who get very, very sick when they have a migraine, right? They can't go to work, they may not be able to eat, they can't function, they can't drive. So we want to make sure that we're trying to restore our patient as much as we can. So our short-term goals and our long-term goals are a little bit different. Short-term is, again, for those abortive therapies that we'll have for our patients, and our long-term is going to be more about prophylactic, like how can I prevent them from having this occur again in the future. So when you're looking at your short-term, very important for you to look at the different times that we have here and how quickly we're typically wanting our patients to respond. So on here, what we're saying is, hey, I want them to be able to regain some type of function within an hour of me giving treatment. Sometimes you will see where people will give at least 2 hours before they're expecting to see some type of result. And we'll also see this when we look at our trip-ins and how often we're going to redose them, because we give that medication some time to work. If it doesn't work, sometimes we can retreat them with that same medication, or we can say, all right, I'm going to escalate you to something different. Okay, so we'll get into that in a little bit. But what I want you to make sure that you're understanding is that we should see some functional improvement. We should see some improvement in the pain that that patient is feeling. And if we don't, then that means that our treatment approach needs to change so that we can help that patient, whether it's another dose or if we are changing that medication altogether. Okay? Your long-term, this is again just trying to prevent that headache from happening, improving their quality of life. I just don't want this to be a reoccurring thing for that person to where they can't function every day, right? So now I'm trying to say, hey, I don't want you to keep using your abortive therapy all the time. If I see that you continue to use your abortive therapy, then that means that I'm not doing my job as a PA to make sure that you're managed, right? So I'm going to put them on a prophylactic treatment, and you'll see when we talk about some of our medication overuse headaches that our patients can get, that's also why we will try to go ahead and put them on prophylactic treatment sometimes. This is a MIDAS scale, or like a scoring system. When you have your patients come in, they tell you that they're having migraines, or they think that there's a migraine, you diagnose them, and you want to say, hey, let me see the severity of this. I don't need you to remember all of these scores. I just want you to remember what the name is of the scale that you're using. So a MIDAS scale, right? So you have your different grades, grade 1 to grade 4. If you hit grade 4, it's more severe, of course, than your grade 1, okay? So as the number increases, the severity is increasing in these patients. A lot of the times whenever we see these scores, the more debilitating it is, means that the number is going to be higher. So if I told you that I had a MIDAS score of 7 or something like that, then you're going to be like, oh, this is very debilitating for my patient. And remember, one of my goals was to make sure that my patient couldn't function. So now that means that I probably need to put medication on board for this patient to manage those migraines that they're experiencing, okay? So again, several different types. I just want you to look at the MIDAS, and the reason why I want you to pay attention to the MIDAS is because it comes up whenever we're looking at our migraine treatment options that we have. So, depending on how your patient is presenting, there are several different ways that you can attack treating that patient. So we have what's called a step care across attack approach. Let me get my laser. So you have your step care across attack approach, your step care within attack approach, and then stratified care, okay? So your step care across, this is a lot of your patients where they're telling you that they're having migraines, and then you're gonna say, hey, here's this NSAID, whichever NSAID you choose, if they can tolerate NSAIDs, right? But you give them their NSAID and you're like, all right, here's this medication for you to take, and then they're gonna take their medication. What this is saying, when you say treated, that means that you had success. Your patient responded to that medication in less than 2 hours. They had a good response. Their pain started to decrease. They were able to function again. And when I say function, it depends on the severity of some people's migraines, and it depends on how they respond to medications. Sometimes we'll give patients medications while they've had a migraine, and even though we treated it and they're responding to it, they're tired after they experienced that migraine. Okay, their body is just tired from the headache that they had. So make sure that you're differentiating the two on the test. Just, it won't be you differentiating between anything, okay? But understand, when we're saying treated here, that means that I said, oh, they were successfully treated with an NSAID. Or if I said, oh, they took an NSAID and 5 hours later their headache was still the same, their pain level was still the same, we didn't treat that person, okay? So you're expecting to see some type of response within 2 hours. So I treated them with that first, I treated them with an NSAID their first headache, it worked. I treated them with an NSAID their second headache, great, it still worked. I treat them with a third one, it worked. If I'm still within a month and I'm having this many migraines, then you're like, maybe you're not very well managed with an NSAID. So I then would say on that fourth headache, I would offer them a triptan. Now, in real life, do we always do this? And the answer is no, okay? Sometimes your patients are not gonna come in when they have migraines. They're not gonna be able to see you most of the time whenever they're having a migraine. But if they have that history and they're telling you like, hey, how often, you're talking to them, you know they have migraines, and you're like, well, how often are you taking your NSAIDs, right? Because those have side effects too, especially if I'm taking them often. And if I'm telling you like, oh, I'm taking it like 3 or 4 times a week for my, that's a lot, right? So if I give you an exam scenario, it's gonna be like, okay, you can tell that they're having or they're needing to now be on a triptan. The other way that you're reading this is, let's say on my first headache, I took an NSAID, I didn't get any resolve, right? My pain level was still the same, my head was still throbbing, I never got any resolve with that treatment, okay? I had another headache. I didn't get any resolve with that treatment. So now I failed an NSAID twice. It did not work for me 2 times. So you can automatically now offer me a triptan as well. You don't have to wait for me to have that third headache and be like, well, let's see if the NSAID works now. It failed twice for me already, right? So this is saying if you had 2 unsuccessful responses, then you could say a triptan is available to that patient. Now, you can have where the first headache, it worked, the second one it didn't, the third one it worked, and this is that art part of it, right, where it kind of gets messy outside of our science, where you can say, hey, I can order this triptan for you, have it on your profile, or we can go ahead and we can start you on triptan now. Do you want to start the triptan, or do you want to try an NSAID again and see if it works? Because maybe that one time, or the other 2, like this one working, this one not working, and then this one working, maybe on that fourth one it would work again, okay? So real life practicing, you would play around with it. Exam purposes, if you have a question like this, it will be very straightforward on, okay, they failed it 2 times, or they had more than 3 headaches, and now you're trying to say, this is their 4th headache, and you want to treat them with a triptan. Your step care within attack. So this is one of your patients who is currently having a migraine. So I come to you, I have a migraine, right? Or you know I have a history and you prescribe my meds. And you gave me an NSAID, and I took my NSAID, and I still did not see any pain relief, and I didn't respond within that 2 hours, right? So it's like 3 hours, and I was like, oh, now my NSAID is kicking in. Now I can feel my relief, right? That's still considered a failure because it didn't happen within the 2 hours of me taking my medication. So what you could do is you could have on board already, or have ordered for them already, a triptan for them to say, all right, that 2 hours passed, they didn't get any resolution, now let me give them a triptan, and so they can take that triptan, okay? So they would start with the NSAID, 2 hours pass, I don't feel any better, my pain hasn't reduced down to a 0 or a 1 if it was very severe, and so now I'm like, all right, and I'm not going to give you a score, I'm just going to tell you like, hey, they didn't have any relief in 2 hours, okay? So then you would know, all right, then I can give them a triptan. Your stratified care. So this is, you have diagnosed that patient with this migraine, so hey, you have migraines. I'm like, great. And then you look at my MIDAS score, and you, depending on my MIDAS score, you can decide if you want to do NSAIDs or if you want to do a triptan. So if I'm at a grade 2, then you can go ahead and try me with the NSAID because I'm not as severe. Remember, as my numbers continue to increase, my severity was increasing. So when you see your grade 3 or your grade 4, that's when you can see, all right, I'm going to automatically say, here's this triptan for you to use. In real life, this does not preclude you from automatically also giving them an NSAID for them to use if they can tolerate NSAID. Because maybe they will, even though they have the severity, maybe they will respond to an NSAID. Most people who have very bad migraines are not going to want you to test out the NSAID theory. They're probably going to want to go straight to their triptan because it's uncomfortable for them, right? And depending on how bad it is, especially once you hit grade 3 and grade 4, it's more debilitating for them, okay? So, big idea here is if I have more than 3 headaches, then I need to get a triptan, or if I failed my NSAID twice, anywhere in this window, then I get a triptan. If I have not had a response in 2 hours, triptan. And then here, if I have a 3 or a 4 for my MIDAS grade, triptan. Everything else is NSAID. Okay? So when I was talking to you about this was just giving you a background so you would understand what the MIDAS grade was, but I do not need you to remember everything that's on here. I literally just need you to remember, hey, if I have a 2 versus if I have a 3 or a 4, what's happening. Okay? All right. Oh, this was just talking about how we used to treat migraines back in the day. They'd give them a nice little hole in their head and try to help them feel better for their migraines. Thankfully, we don't do that anymore. What just happened? Hold on, my computer decided not to participate. Okay, there we go. But this was what they call the trepanation, and they would go in and do this to help treat someone's migraines. This looks like it would just make it worse. But okay, our non-pharm treatment. This seems very like it's not helpful, but again, when I first started, I was telling you like the triggers are a very big thing. If you can avoid a trigger, avoid it. Also, darkness, so you'll sometimes see people come in and they'll have on their shades and you're like, it's like you're inside, bro, relax, take off your shades. Sometimes they might have a migraine, right? So making sure that you're understanding that sensitivity to light and that resting is very crucial for some of your patients who do have this occur, especially if they don't like medications. A lot of these non-pharm remedies are very good. Ice on the head can also help. So when you look at this, depending on if you find out a trigger and it's like a stressful situation, you can also refer them so that they can have management to help them kind of manage that stress, okay? So sending them to therapy, different types of things, biofeedback. You can also have acupuncture done. So there's several different ways, bless you, that we can help with our patients with this. But big thing that we try to do is avoid the trigger. This is our treatment options that we have for migraines. So there are several different ones that we're going to look at. So when you're seeing your abortive therapy, this is just saying, hey, I have an active headache. What am I trying to do to prevent that headache from occurring? I want it to stop, right? I want to shut it down. How long or how many hours do I have before I say, hey, this is a treatment failure? 2 hours, okay. How many headaches can I have in our step care across approach before I need an NSAID? I can have 3 headaches. How many failures do I need to have? 2. So we said 2, remember 2, right? 2, 2, 2, okay. So this is our different types of abortive therapies that we have. This is going to be the medication that you can use in this box, and then this is your recommendation. So when we talk about the strength of a recommendation, yearly this could change, right? The way that we get recommendations when we're looking at guidelines is because they will sample the population and say like, okay, how many do case reviews, case studies, different things like that, and say, all right, how many people did we have that successfully responded to treatment? So when you're looking at this, when you see your strong 4, those are the ones that I will typically focus on and that we'll talk about more in our slides, because those are the ones that we have the most evidence for to be effective in our patients who are experiencing migraines, okay? So you see your aspirin, acetaminophen, and caffeine. This is all one pill, okay? So it's not like one of them individually. This is a combo pill that we're going to talk about. Looking at your triptans that you have available, we love our triptans. They're the best, like this is our mainstay when we're talking about like our migraine medications. Then we have several other options here. A lot of these are becoming newer medications. A lot of these were newer when this came out, and as time goes on, you'll see where the recommendation for this is going to definitely pick up, and some of them I think I went through and tried to edit them. When you're looking at your blocks that they have, so there's several different blocks that you can do on a patient. Again, not very strong for these as much. And then also we have Botox that is available, and that is also going to depend on your patient. Most of the time when we're doing that, that's more so our prophylaxis treatment that we're going to talk about, our Botox in. Yes?
I was curious, does the recommendation number have any relevance?
Oh, no, so this is like in the guideline whenever they put them so that you can find it within the guideline. And it gives you an explanation of like what the panel talked about. So the recommendation number is not anything that you need to worry about. Just looking at this, and what I want you to pay attention to is going to be like our slides that we're going over. When I want you to specifically remember a chart, I'm going to tell you about that chart because there's one that I want you to know. So our challenge question, 50-year-old female, no past medical history, needing assistance with her migraines. She's tried NSAIDs, but they failed to relieve her pain one time out of the previous 5. What is the most appropriate recommendation for this patient? She's had 5 failures. Right? So let's say she only had 1 triptan. Like let's say she only she didn't take any, this is 2 questions, the way that I put this here. So the first one, if I give you a time frame and I said that this person had 1 headache in a month, right, versus me telling you that she had 5 headaches in 1 week, would you be more prone to treat her with a triptan if I told you that she had 5 headaches in a week versus her having 5 headaches in 1 month? Yes. Right? So the time frame is going to play a role. We're going to define the time frame as well. This was why I did this question like this. So if she had 1 headache, right, and she was fine in the fact that we treated her, let's say 3 times, and 2 out of those 3 times she failed, what would I be doing? Why are you doing a triptan? Because she had 4 headaches, but also she had 2 failures, right? Sorry. I don't know why my sound is on. I'm also leading the DHA course, but I told them I had to step away. So it's popping up their answers, and hopefully it doesn't keep doing that. Now, what if I told you that this person had 3 failures when she was taking her NSAIDs, a triptan still? When you look at this and you seeing this switch to another NSAID, you would only do that if, like, your patient was saying there was some reason why they couldn't tolerate it or it didn't work and that was their very first try that they had something, then you can try to switch to a different NSAID. You would never take the dose and then just say, I'm going to double this dose and expect for my response to be different. Because when I double my dose of my NSAIDs, what am I increasing the risk of? The side effects, okay? So don't ever think to just say like, okay, I'm going to increase the dose of that medication. If they're at their max dose, then you're not doing that. If they're not at a maximum dose, then you could potentially do that, okay? So I would have to tell you like, hey, they're on their max dose of whatever it is. Don't say, well, continue to increase their dose. We're hurting our patient now, okay? So make sure that you're understanding kind of how to treat your patient. Don't just tell them to avoid the trigger, because what if I can't avoid the trigger? You still have to treat the issue at hand. I still have a migraine, okay? And I still have failures with my treatment. So when you look at this, if I were just to tell you that she had one failure, and I changed this number of my migraines to 2, I could continue to have her on an NSAID. If I changed this and I said she had one time where her NSAID didn't work, I could continue on an NSAID. And like I told you, for the exam, I wouldn't ask a question like this, because this is very ambiguous on how you could answer this question depending on how you want to approach it. Could I still give her an NSAID? Potentially, yes. Okay? So out of this, looking at this answer, what I would be doing is I would either say, I'm going to switch her to another NSAID, or I'm going to switch her to a triptan. Okay? The question would be clearer. This is a discussion for, like a question for us to have a discussion. But this would be a lot clearer if we had this as one of our questions.
Question, can you clarify again why would you switch to another NSAID?
Because some people respond differently to different NSAIDs. In the situation with migraines, like when we're talking about them responding to their migraines. Some people will tell you like, oh, when I have a migraine, if I take ibuprofen, it's better than if I were taking naproxen. And they have a preference. I haven't experienced that myself. Usually when one doesn't work, none of them work. But again, it varies depending on the patient. So we were talking about our acute migraine agents that we had, and these were just us saying, hey, acute means I'm trying to avoid it. I'm trying to stop it. They're actively having a headache. So we have our different categories that you're going to look at. You have your over-the-counter medications, our prescription medications that we're going to talk about, with our triptans being our most preferred thing that you're going to prescribe, and then our miscellaneous, which has that hit or miss response that you can get. When we look at those antiemetics, for the most part, that's us trying to treat some of those symptoms that our patient is going to be having, more so than actually like treating the etiology of why they're having a migraine. Definition that we're going to talk about is a medication overuse headache. So this is essentially telling you I have migraines and I am using my medication a lot to try to abort that migraine. And so if I continue to use my medication over and over and over again, then I can get what's called a medication overuse headache. So essentially what happens is like the brain is going to start to adjust to the levels of receptors that is required of it, right? So the levels of receptors can go up, it can go down. And so when the patient stops taking the medication, which is our fix to a medication overuse headache, when the patient stops taking the medication, the body's natural supply of serotonin won't be enough to activate those newly downgraded serotonin receptors, and so then that headache will come back, and then you'll try to continue to just chase the headache, okay? So if they have medication overuse headaches, what you're going to do is let them know that, hey, you are going to experience headaches for a little while. They're going to have to go through that period, and then you can start their medications again once they have gotten out of that period, okay? So medication overuse headache, we're going to talk about these, make sure that you're paying attention to it. Most of our therapies that we see, we're going to try to have our patients take them no more than 2 days out of the week for their treating their headache, okay? So what we're trying to do is make sure that they're not using it over the 2 times in a week, and we're trying to make sure that if they do experience MOH, that they stop that agent, go through that period that they're going to have with that headache, and then we can start the agents again once that wears off, okay? It usually takes about, sometimes most patients are good after like that 3-week period, but they have to essentially let the half-life of that drug, get that drug all the way out of their system, that withdrawal period that they're going through. Okay, Tylenol. I know y'all are sick of seeing Tylenol, we've seen it a lot. When you're looking at this, just make sure, again, to remember that this doesn't have any anti-inflammatory properties, no antiplatelet properties. With this, we do get some pain relief from it. So that's why you will see that some people will use your acetaminophen or your Tylenol when we're talking about some of our headaches. This may be something that some of your patients do use as a first-line medication, especially if they're on that milder end of the spectrum with those migraines. But this is also an option for us to try if our patient has some type of contraindication to them using an NSAID. If they can't tolerate an NSAID, typically what we do is we will try our acetaminophen. But that does not mean that they will have great results from it. And if they don't have great results from it, then it's not abnormal for you to be like, all right, here's this triptan for you, okay? So we will try to go to this, but this is not one of those ones that had very strong evidence for us to be using it by ourselves. Again, just make sure that you're understanding, not our preferred thing. We would prefer to use one of our NSAIDs over using acetaminophen, but if there's a contraindication or if they're on that milder end of the spectrum and they don't want to use an NSAID, we can opt for Tylenol. Looking at our butalbital and Fioricet and Fiorinol. So these are just several different ways that you can see the medication in combo to be used for migraines. This used to be very popular back in the day. We don't use them as much anymore. So you have this has the barbiturate, the butalbital is the barbiturate portion that is added to our acetaminophen. What you can see with this is that you can have several respiratory depression, things like that are occurring because of the barbiturate portion of it, okay? So make sure that if someone is taking this, that they are not someone who's very sensitive to medication, or whenever they take their first dose, that they're at home so we can see how they respond to it. Because if they do have that drowsiness, you don't want them to be driving. You don't want them to be at work, right? Because they're going to fall asleep while they're driving, fall asleep at work, and not something that we're trying to do. So make sure that we're looking at us prescribing this. Again, over the years, we have found out that this is not as effective as we used to think it was, so that's why you don't see this used as much. So you see two different formulations. So you have your Tylenol, which is abbreviated as the APAP. So this is your Tylenol with your butalbital and caffeine, which is called Fioricet. Okay? This one is not a controlled medication. When you look at your Fiorinol, you see an aspirin in there, right? Butalbital and your caffeine. And this one is a C3 medication. So can you tell me why you would think that one is a controlled medication and one is not a controlled medication? What would be your assumption on that? So it's about the aspirin. What do you see about the aspirin as to why you would say, okay, I'm going to make this one a control versus the one with Tylenol not a control?
The high dose?
Do I have an antidote for me to treat aspirin?
No.
If I take too much of it? I mean, a real good one? No, right? Versus for my Tylenol, what do I have? Nat, right? So if I had a person who took too much of their Fioricet, I can potentially help them and I can reverse it. I'm going to control how much aspirin I'm allowing this person to have to potentially be like, oh, I have a headache. When people have migraines, you will see them do interesting things just to get rid of that migraine. So then they can continue to use this medication without that observation or your oversight as a PA or as a doc, right? So that's why we have this one more so as a control medication. So your Fiorinol is a control, C3, that's what the control portion of it is. And then you have your Fioricet, which has the Tylenol, and that one is not controlled. Again, you see that we don't see how effective it is, so that's why we're not using it as much. So just remember, I'm not using this one as much, and that I have the potential, because of that butalbital portion, the barbiturate, to have withdrawal, to have the drowsiness, to have the potential of that respiratory depression, those more serious side effects that we're worried about. Okay, our Excedrin. So this is available over the counter. And with that, we think sometimes like, oh, that's probably not very effective. This was one of those ones that we had very good evidence for with the effectiveness. So this is something that we can see used in our mild to moderate migraines that our patient will be experiencing. This has the acetaminophen, the aspirin, and the caffeine all in the one pill that they would be taking. Mechanism of action, make sure that you're looking at that, but just make sure you're understanding essentially what's happening is we're trying to say, I want to promote vasoconstriction. There's several different theories as to how and why migraines happen, bless you. But the thought is that, let's just say like that the vessels are very open, right? So my blood is able to flow faster, more freely. And so that's causing some of the pain that the patients will feel. So when we say, hey, you have a migraine, sometimes I'll tell patients whenever they take their medication to drink it with a soda that has caffeine in it to try to help that the medication work faster. Or coffee that has caffeine, because we want that vasoconstriction so that we can try to close things up and make it slow down for them, and that helps their headache. So in this situation, that's why you see, even when we were talking about albuterol, it was paired with caffeine because we wanted those vasoconstrictive properties from there. So just looking at that antagonist at the adenosine receptors, and then you have that caffeine portion of it, which is causing that vasoconstriction. I already told you about that mild to moderate. Now, some people will have those prodromal effects where they start to feel that they're having that migraine before it actually comes, and some of your patients will not. So as soon as this is so annoying because it is muted. It's muted, but it's playing sound for y'all. So just make sure that you're understanding, again, mild to moderate, and first sign of pain. The longer that they take, no, it's not funny. You all notifications. Okay. I like how y'all are trying to help me. Y'all just laughing at me. Jeez. Okay. So when we're looking at this again, this is what we were talking about before with our, I don't need you to remember the dosing here on how they're going to be taking this, but what I do want you to remember is that medication overuse headache, and the fact that if they're continuously taking this medication or they're taking it over what we would tell them to typically take it at, so over that max dose, they can have withdrawal from the caffeine. So the same thing is if I were drinking coffee every day and then I stopped drinking my coffee every day that had caffeine, right? We say that people will get like a headache, they go through the withdrawal of the caffeine. The same thing with these medications that they continue to take, especially Excedrin. And we see this a lot with Excedrin because it is over the counter. People take it and they buy it themselves. They don't need us for that. They don't have to come to the pharmacy to get it. They don't have to go to you to get it. And they will continue to take it because it does work for them, but then they don't realize the fact that they can have that MOH with that, okay? So just make sure that we're letting them know about that caution. Our NSAIDs, same mechanism of action that you've seen before. Make sure that you're remembering that this is most of, that we are reversibly binding to that COX-1 and that COX-2. When we're looking at our migraine, we're also thinking that it's helping decrease the inflammation that they may be experiencing in that trigeminal system, which is where we are going to have a lot of our activity. And when we talk about our triptans, we're going to talk more about that area. So just make sure that we're trying to say, hey, I want to decrease and prevent that inflammation that they're experiencing, which is what is going to also be contributing to that pain that they're experiencing, okay? First line option that we can see used in our mild to moderate, especially if they're not having any of that aura. So no nausea and vomiting will typically be associated with us going NSAID first, okay? And our patients who have like that nausea and vomiting, most of the time we're going to start more aggressively with them. You see here that if I had responses in the past, and that's why I was telling you, like on the exam, I would be very clear with this, but in practice, what you can see is sometimes I'll say, hey, that NSAID works for you, we're going to continue to put you on that NSAID, but I'll order this prescription for you just in case you need it, just in case that NSAID stops working, or if you're starting to use it more than I would like for you to use it. So here, what we're trying to say for our MOH is they should not be using this, their NSAID more than 15 days out of the month, okay? If they're starting to use it more than that, then we're worried about MOH occurring in that patient, okay? So, circle, underline, all of these when we start to go through these with your days that you have for MOH. How long can my patient be using this? Because then that's your cue to say, all right, you're not using this NSAID anymore. I'm going to switch you to a triptan. Okay. And then you see our NSAIDs that they're preferring. We have our ibuprofen, our naproxen, and our aspirin, but again, patients can use any NSAID, and they typically will have a response to their treatment. Okay, our triptans. So this is like our gold standard, where we like to be, and sometimes where most of your patients end up. You do have some of your patients where they can always just stay on their NSAID and they don't ever progress to where they're needing a triptan. Some of your patients will end up needing a triptan. So when we're looking at this, your receptors, just make sure that you're understanding that it is doing the presynaptic 5-HT receptor agonist, and then it also has some of the additional activity in other serotonin receptors. Not going to make you remember the subtypes of the serotonin receptors, just remember that it's working on several different serotonin receptors. So what you see here is that your patient has whatever that trigger is that they're going to experience, okay? And then you have a release of the vasoactive peptides. So this is what you're looking at here. So your vasoactive peptides, which will be like CGRP, and we'll talk about some drugs that are going to target your CGRP as well. And so that will lead to that vasodilation that we were talking about, and that's where I was telling you your patient can potentially be complaining of the pain and everything that they're going to feel, because that's when your brain gets the signal that, hey, there's something wrong, I'm not feeling well. So that's where the pain gets stimulated from. And so what we're trying to do is say, all right, let me give you some type of, then you'll see your parasympathetic is going to say, right, rest and digest, right? So that vasodilation continues to get sustained. And so that prolongs that person being in that migraine state, that prolongs how long they're in pain. And so what we're trying to do with our medication is to combat that. So what we're doing is we're going to then say, hey, let me get to those serotonin, which is abbreviated as your 5-HT. Let me get to those serotonin receptors, and then I can cause some vasoconstriction. And then what that will also do is send some feedback to the brain to say, hey, stop with the vasopeptides. I don't need them. I don't need any more vasodilation. I'm trying to vasoconstrict so that I can decrease the pain, so that I can decrease that vasodilation. Okay? So that's where our triptans are working in this system of what is happening in a migraine. Okay? So your triptans are specifically focusing on your serotonin receptors that you have. Okay? And then we'll talk about some of those other vasoactive peptides that are going to be targeted in some of our treatments. Okay. These are all of the different triptans that you have. You will see that some of them have several different formulations as well. This comes in handy when you have people who do vomit, right? I don't want to take something or have to swallow a tablet if I'm throwing up. So I have different options. I have injections, I have nasal sprays, I have ODT or orally disintegrating tablets that I can use to put under my tongue. So there's several different options that you have depending on how your patient presents. So if they tell you like, hey, most of the time when I get a migraine, and it may not be every time, but most of the time I get a migraine and I'm vomiting, then we need to make sure that we're giving them a delivery system that they're not going to vomit, because then they're not going to get the medication that they need to treat the headache, right? So looking over here, these are our drug names that we have: amitriptyline, naratriptyline, provitriptyline, sumatriptan, with several different options that you can use. This one is your sumatriptan with your naproxen. So what we did was we added our triptan with our NSAID to get a greater response potentially for our patient without them having to take two different medications. So they could just take that one pill that they would have. Your rizatriptan, elatriptan, and then your zolmitriptan, again, you have two different formulations. So where do y'all think we typically start when we put someone on a triptan? Which drug do you think we typically choose? We typically choose an oral sumatriptan most of the time, depending on how they present. But I love sumatriptan because look at all of the different formulations, right? So if somebody's migraines do progress, I may say, okay, I was giving them this tablet, but now I can give them ODT instead. That's going to go under their tongue and it's going to dissolve and then get to their bloodstream. Oh, okay, well they don't want to taste that minty taste that can come along with that med. I can give them the intranasal. Okay, so there's several different things that we can do in different formulations that we can have for our patients. So what I want you to remember here is your drug name, and then these little caveats that we have over here to the side. I created a chart for you because I want you to remember how soon can you redose the patient, and it's harder to remember it this way, so I made a chart for you to remember it on the next slide, so we'll talk about that. What I want you to see here is that your amitriptyline has a sulfa group, so that's the big thing that I want you to remember there, because we have several patients who have sulfa allergies, so we need to make sure that we're watching out with our amitriptyline. This one, our naratriptyline, we'll talk about this, but we have several medications that our patients who present with menstrual migraines, so before they have their menstrual cycle or right whenever it's starting, they may get migraines that also start with their menstrual cycle. So we can essentially kind of prophylactically know that we need to order this for them, and they will use that as an abortive medication whenever their cycle does start. Looking at our provertriptan, again, we also have this one for our menstrual migraines as well. Both of those have long half-lives, your naratriptan and your provertriptan. Your rizatriptan in your patients who are taking propranolol, you'll see that we try to decrease our dose, make sure that we don't get it too high due to the interaction between those two. But I just don't worry about that. I'm not going to ask you that because that's very nuanced and you don't need to. And then your elmatriptan, with this one, just making sure that if somebody had something on board that was like an azole, right? So something that is a very potent inhibitor of your 3A4, you're going to wait 72 hours for that SIP to be available so that you don't have increased doses of your elmatriptan. And then your zolmatriptan, you see that you can use that for your menstrual migraines as well. The nasal spray is still the same active drug, so technically you can say that the nasal spray is also for those menstrual migraines as well, okay? So here you're remembering which ones can I use for someone who comes in with their menstrual migraine, remembering the several different types. I will not make up a formulation, okay? So just listen to what the patient is having, how they're presenting, and that will guide which formulation you would use. So if you had somebody, again, who is vomiting, and you see a sumatriptan tablet over a sumatriptan injection or like their nasal powder, then you would pick the injection or the nasal powder, not the tablet, right? Because I may vomit the tablet up, okay? So when I say formulation is driven by your presentation of your patient, that's what I'm meaning. This is the other part of that chart that I wanted you to remember, but this is when do I repeat the dose of the medication. So what this is saying is, hey, Raina, you had a migraine. We're trying to abort that migraine, but it's not working, right? So I took my first dose, and then I wait between 1 hour and 4 hours, depending on which medication I take, before I can have a second dose. And we typically won't do more than 2 doses in that 24-hour time frame. The other thing is, if for some reason I go and I talk to my friend and I'm like, man, I had this migraine and I just took my sumatriptan, and she's like, oh, but guess what? I have naratriptan, right? And then gives me illegally, okay, because you're not supposed to share prescriptions, but then she gives me her naratriptan, I can only take 2 doses of any type of triptan, okay? So just because, like, let's say I said, oh, I took my 2 doses of my sumatriptan, and she's like, oh, but I have naratriptan, I shouldn't be taking that, because then that's a 3rd dose of a triptan. I can only always take 2 doses of a triptan within that 24-hour period. You still have to wait, okay? So your 1 hour, the only thing that you only have one, is going to be your sumatriptan injection. And then your 4 hours, you only have one, is your naratriptan. Everything else is in between that 2 hours, okay? So my 1 hour is an injection of my sumatriptan, my 4 hours is my naratriptan, and everything else is your 2 hours, okay? So you can look at it that way, or you can try to look at it this way. I just made it into a chart because I feel like it's a lot easier to know, hey, I just got to remember this one, and then remember everything else falls in between. Also remembering the fact, again, my triptans, I can only take 2 of those doses in 24 hours. If I mixed and match, fine, but still only 2 doses. I can't take 2 of one med and then take 2 of another med, okay? So 2 total of any triptan. This is just showing you that there are several different formulations. that are available to your patients, like we already talked about. And when we come back from our break, we'll start getting into our triptans a little bit more. About these drug name slides and the comments that are over to your left. I had to turn around to do that. Real low. So this goes to this particular line. This goes to this particular line. This goes to this particular line. Okay? Don't make that face. I'm answering group questions. Don't look at me like this. That's why y'all look at me like, watch me looking crazy. Because I have all of y'all looking back at me like, and when y'all text and y'all are laughing, I'm trying to figure, I want to read the text too. I know y'all be talking about me, it's okay. It's okay. So your rizatriptan, your elmatriptan, these are going across. I also had a good question about somebody asking about the sumatriptan, right? And when you're looking at menstrual migraine. Some of our drug companies in certain situations, they will go through to get indications for their specific medication. Could you potentially use one of these for a menstrual migraine? Yes, for your exam, the answer is no, okay? So what's on here? Real life, you probably can put somebody on it and it's probably gonna work, okay? But just for your exam purposes, just stick to what is on the slides, okay? All right. So, our triptans, we already talked about these as being our first line. We want to use these. We love these. They're great medications for us to use. Looking at our moderate to severe cases as to when we're using this. This looks at how we were looking at our Midas scale, right? And we saw that when we were hitting that 3 or 4, our more severe, that's when we were using it. Our failures that we had in our treatment, that's when we were going to our triptans. So this is again like our number one, like this is our go-to. This is our ride or die, right? When you're looking at this monitoring, what this is telling you to do is when someone has coronary artery disease, okay? I would tell you that that patient had coronary artery disease. If they had coronary artery disease, what you would then do is you would do your ECG. You're going to monitor their vitals when you give them that first dose of their triptan. And this is going to make sense when we start to look at our side effects for our triptans, because what will happen is some of our patients will have like chest tightness, several different symptoms that could worsen their cardiac condition, okay? So anytime you see that coronary artery disease, if they're at risk of coronary artery disease, that's when we're saying that first dose, you would order the medication for the patient and you would give it to them in clinic, okay? Again, making sure that if you think or you're suspecting and you haven't diagnosed someone yet with coronary artery disease, then the same thing that we're talking about applies as far as us getting that EKG and then doing, or ECG and doing the, making sure that we're monitoring their vitals. First dose, again, would be in clinic, okay? So, your obese patients, your patients who like to smoke, diabetics. Remember, diabetes keeps coming up on everything that we talk about because they are just more prone to having issues occur with them, okay? So just make sure that you're paying attention to these two things. This is when we are saying we're going to monitor our patient. We're giving them that first dose of their triptan that they ever have in the clinic, okay? We don't have to necessarily wait for them to have a headache. What we're doing, what we're monitoring is their vitals, to make sure that they don't have that chest, the chest tightness and stuff that we're worried about. Looking at our administration considerations. So remember, when we look at this, we have several different formulations and the ways that some of these medications are made. We have oral options, we have subcutaneous options, intranasal options. I will tell you what type of formulation that you have. Again, you're picking the best option based off of how your patient is presenting, okay? So your big thing that you're looking for there is just your nausea and vomiting. Pay attention to your PK property. So on this, I said all that to say, when you're looking at that first bullet under your administration considerations, I'm not gonna ask you that in a way of which one has an oral versus which one has an IV versus which one has a sub-Q. I will tell you, but based off of their symptoms, how they're presenting, I want you to choose the right formulation. So if I'm throwing up, oral is not a good option for me, right? So like, just knowing that is all I need you to know. Now your PK properties. This is looking at the severity, right? Like, how am I presenting again? How long or how quick am I expecting for me to have some type of resolve? So when we talk about our sub-Q or our intranasal, those are hitting our system very, very quickly. Those have very, very fast onset. This is sometimes beneficial for your patients who don't have those prodromal symptoms, and they're very, very severe whenever they have their migraines. This is very good for them because if I have a very, very debilitating, severe, bless you, migraine, and you give me something that's an intranasal or I can inject myself, then I'm likely to have a quicker response, right? It's hitting my system a lot faster than me swallowing a tablet and waiting for it to go through that AbbVie process, okay? If you don't respond to one triptan, you could potentially respond to another one, okay? So just because I'm saying, hey, I can't take sumatriptan, doesn't mean that I can't take naratriptan, doesn't mean that I can't take rizatriptan, and so on and so forth, okay? So you can switch to a different one. But remember, no matter what, if I took that first dose and I didn't respond, even if you were to give me a second triptan that wasn't the same name brand or the same generic, I still have to wait 24 hours before I get over those 2 doses. So hopefully that second one that you chose for me actually works. Sometimes what we'll do, especially if they're in our care, when this happens, we can give them that first oral option, and if that oral option doesn't work, then we can tell them, hey, we're going to do an intranasal dose, or we'll give you a sub-Q dose or something. Sometimes I have also seen where some of our PAs or our providers would give them an oral option, and then they would give them a backup of the intranasal or sub-Q just in case that oral didn't work and that patient had very, very severe migraines. So another option, you can give them 2 different formulations to say, all right, if this one doesn't work, try this one, and hopefully it hits their system harder. We already talked about this non-oral option, so again, just making sure your ODT, we don't consider it as an oral option even though it's going in the mouth because it does quickly dissolve and it's going in through under their tongue. Okay, so they're not swallowing it, it's not going to be in their GI tract that way. Then we'll be worried about like our tablet and then throwing that up. This is different than our 15 days that we talked about with our NSAIDs for our MOH. Now we have 10, okay? So I'm expecting for them to use this less frequently than what I was expecting for them to have to use their NSAIDs with, okay? So kind of think of it as like this is a stronger medication and it works better, so I shouldn't be using this one as much. That's kind of how I try to remember it. Adverse effects, these were what we were kind of hitting on already. So I have my chest symptoms that I can be experiencing, and that's the biggest one. So that's why we're worried about our patients with coronary artery disease or our patients who are potentially at risk and we have not diagnosed them yet. So just make sure that you're understanding, hey, that ECG might be something that I'm doing. That first dose will be administered while they are in my care, while they are in the clinic, okay? Looking at some of our other options that you have, flushing, different sensations. Is this side different than yours?
Some of us probably have it cut off.
Yeah.
It's a notability or something.
Okay. You know, in these phones, when everybody started getting the phones, I'm like, what happened? Okay, I was making sure I downloaded the right one. When y'all do that, when you, even for everybody else who's using Notability, when you save it, when you download it and save it as a PDF, like it still does this? Okay, so you have to download it and save it as a PDF first and then transfer it to Notability? Okay. Okay. Y'all download it, save it first, and then put it in Notability, okay? Okay. Contraindications. Oh, so also looking at our adverse effects. We already talked about this. Anytime I'm injecting myself, pain, redness at the injection site, right? Makes sense. But whenever you see your hypertensive crisis, not something that is common, rare for this to happen, but if we don't catch it, can be very severe and life-threatening for our patients, okay? So make sure that you are paying attention to that. Contraindications. So I just told you about the fact that we can have a side effect as our hypertensive crisis. So if somebody has uncontrolled hypertension, then I'm going to be very wary in that patient. I'm not going to use this medication. If I told you that they had controlled hypertension, then you, as the provider, when you're monitoring it, then you can see like, oh, are they responding to my med or are they just out of control because Raina doesn't take her meds? she has uncontrolled hypertension, okay? So if you see uncontrolled hypertension, we'll stay away from our triptans, ischemic heart disease, anything that we think about with any type of coronary artery disease type of etiology is all going to be avoided here. Prince metals, right? That was that angina that our patient would feel. And then don't worry about the type of migraine because we're not getting that detail. But there are certain types of migraines where the medication isn't effective and it doesn't work. So contraindicated there. And then we can't use these in pregnancy. We can't use these in pregnancy. Drug interactions. We're going to talk about our ergotamines, which are our older drugs. We will avoid using our triptans within 24 hours of an ergotamine, or if we maxed out our dose of another triptan, we're still waiting again 24 hours before we can take a different one, okay? So you can mix and match all you want, but then once you hit those 2 doses of those triptans, then we can't do anything. We have to wait 24 hours before we can take another triptan or try that same one again with a different dose. Any of our strong CYP inhibitors, because of the way that we're metabolizing our triptans, we want to make sure that we are not taking them at the same time. And then our serotonin syndrome risk, making sure that you're remembering those drug classes because we've talked about these. I do want you to make sure that you're remembering your SSRIs, your TCAs, and your MAOIs that we're worried about. I will put in parentheses, if I did give you this, a drug, I would put in parentheses like, hey, this is an SSRI, TCA, or MAOI, okay? I'll only ask you about those few. Okay. Now, when we talk about serotonin syndrome, y'all have heard about this already, so remembering that this is that life-threatening drug interaction that we could potentially have, and the more drugs that have serotonin syndrome as a side effect, we're increasing the risk of that happening when we add several of them on together. So when they present, your patient may kind of come and they're going to have, these are just different symptoms that they're presenting with. So some cognitive behavioral symptoms, you have your autonomic nervous system symptoms that will be occurring in your neuromuscular symptoms. FYI for this slide, essentially because I'm going to tell you that they have serotonin syndrome, okay? I will tell you what they are having. I'm just giving you again, what is it, right? What you need to know is going to be how do I treat my patient and what are those additive drugs that I can give my patient that can increase the risk of that. Okay, so again, make sure that you remember the ones that I put on the slide. Those are the main ones that I wanted you to know. So on your triptan slide where we had our SSRIs, our TCAs, our MAOs, I want you to remember that. And then the only other one that I want to add to that is going to be your amphetamines and other triptans. So your amphetamines here and your other triptans. I don't need you to remember this whole list is what I'm saying. I'm trying to cut down the list for you. Okay. So I'm not going to expect for you to remember which one is an SSRI. If I give you a drug, I will put in parentheses that it is an SSRI. Same thing for TCA. Not trying to make you go back there. I know it was traumatic, okay? So I'll put in parentheses that it is a TCA. And then the same thing when we're talking about an MAOI, I'll do that. But then for your amphetamines and your triptans, just make sure that you understand those are the other 2 that I want you to pay attention to there. Now, the way that we're going to try to manage this if someone comes with serotonin syndrome is we're going to stop those meds that are causing them to have the serotonin syndrome. So stop the agents, okay? When you do that, you should start to see that your patient is starting to recover. You're going to also try to make sure that you're providing that supportive care for your patient as well, okay? Now, when you're looking at this, depending on how they're presenting, you may have to give them a benzo to help stop that seizure if that is how they're presenting. Everyone does not get a benzo. If I'm not agitated, if I'm not seizing, then you're not worried about giving me one, okay? But if I am, then benzodiazepine. I also have my cyproheptadine that can help me reverse the effects of that serotonin syndrome, okay? So, my big drugs that I'm using here, well, my first thing, I'm going to stop the agent. Supportive care, take care of your patient. If I'm seizing, then you're going to give me a benzo to help me with the seizure. If I'm very agitated, you're going to do that because that's the way that some of your patients could present. And then I also have my reversal, quote unquote, like my antidote that I can use, my antihistamine, which was your cyproheptadine. okay? So this is what I can use to help treat. This is what could spur on the disease for me. So this is what could make me have serotonin syndrome. Yes.
For this topic, just taking on the migraine is not further SSRI. We're not saying that SSRI over migraine.
So usually if they present it like this, you're stopping their treatment until you can get their serotonin syndrome.
Just treatment for migraine with SSRI.
Because both of them are contributing to the serotonin syndrome. So now, just think of it as like I'm at an overload at this point, and you stopping everything, and then you will slowly stack them back on. It's typically what we do, okay? Because now I've put them in this, essentially like a crisis is what I call it, depending on how bad they are, okay? So we're withdrawing our agents, and then we treat how they're presenting, and we also have our cyproheptadine that most of the time we will end up using, because it's gonna block the serotonin, okay? So remember, this is treatment. These are things that have caused the syndrome to occur. Treatment, things that have caused it. Okay, this was my combo drug that I had, my Trexamet. So essentially just combine your NSAIDs with your triptan mechanism of action, and that's what your Trexamet does, which is your sumatriptan with your naproxen, okay? When you're looking at this, again, make sure that you're not trying to remember the dosing, but I have 2 hours to where I can do my repeat dose of this, which was the same thing that I had with my sumatriptan. And then your clinical considerations, make sure that you're understanding that, hey, now I'm getting 2 of these things that work very well in one tablet. Sometimes we have this on formulary and sometimes we don't. So a way around that is you could order just the sumatriptan, and you could order just the naproxen, and you can tell the person to take it at the same time. If we are in that phase where we don't have it, because that's sometimes what we have to do. Okay, your ergotamines. Remember, we're still talking about our abortive care, right? So abortive was another word for abortive? Acute, right? So we're still talking about our abortive care. These are our ergotamines. Ergotamines are super old medications. So when you think about them as like their last line. You are hopefully never going to see these being used for migraines. If so, that means that our favorite things, which are our triptans, which typically work for most people, are not working. And then we'll try, sometimes even before you get to ergotamine, you'll try other things that don't have strong recommendations for them, because these meds are very, they're not clean when you're prescribing them. There's a lot of side effects that come along with them. So when we're looking at this, you see that you have partial serotonin and dopamine activity, and then and also at the alpha adrenergic receptor, okay? So hitting several different things. PK, we don't have very good bioavailability. So a lot of the times whenever we're talking about these medications, doses are very high. And then we also have to give it with caffeine, because when we give it with the caffeine, remember that caffeine is going to help vasoconstrict, but it's also going to help increase the bioavailability of this drug. So now I'm giving a drug so that I can take another drug, okay? And then again, looking at our administration considerations, this is a very huge side effect where a lot of your patients can potentially have nausea and vomiting that occurs with this medication. So we always are going to pre-treat with one of our antiemetics prior to giving the ergotamine. So again, another drug that we're having to give a drug, okay? So that's why you see this kind of like, this is just down the line. Looking at your adverse effects, our rectal, we do see is tolerated better than our oral, but again, when you're talking about a population that has migraines, most of the time they're not going to want to have a rectal formulation of anything given to them. So they're going to look at you crazy when you're like, oh, and it's going to have to be rectally administered. They're like, what else can you give me? Please and thank you, okay? So when you're thinking about this, like, these are the things, when you have all of these drugs at your disposal that we're going to talk to you about, this is how you start to hone what you're going to choose, what you're going to use. Then you can be like, oh, I remember that old drug that's trash, those ergotamines that we talked about. I remember that. since you can't take anything else, that's when I'm reaching for this, okay? So that's kind of how you'll start to build up your stuff. Less effective than my triptans. This is, again, why we're down here at the bottom. This is why we're last line. Medication overuse headache. With this, you see that it's now dropped a little bit more, right? So my days now are at 8. So I had 15 for my NSAIDs, I had 10 for my triptans, and now I'm dealing with 8 with my ergotamine, okay? So make sure, again, you're keeping track of that. When you see that your patients are, the longer that they have a migraine, the less likely that this medication is going to be, it depends on how they present. Because some patients, again, are already experiencing that nausea and that vomiting, and now I'm giving you a medication that may also precipitate, like, or cause you to, again, have more nausea and vomiting. So just be very careful with this medication. It is probably something that you are not going to prescribe. You may likely see it. I have never seen it used in practice. I only have had it on exams, okay? Adverse effects, ergotism. So when we talk about ergotism, this is essentially like a series of things that can happen to your patient from them using the ergotamine. So when you're talking about activating all these adrenergic receptors and these serotonin receptors, you see that you're going to have a lot of that vasoconstriction, because that's just what those receptors are for. That's what we're doing. So then you can start to see where you are clamping down, right? I vasoconstricted too much with my ergotamine, and now I'm starting to see ischemia, gangrene, people losing their limbs, right? Because I have now clamped down too much. I have vasoconstricted, okay? So big thing when we're talking about this. If it gets bad enough, you can also see some people who will present and they will have seizures from the medication. Again, we talked about that vasoconstriction that can happen. So just think about ergotism with ergotamines, vasoconstriction, things are going to die because I'm not circulating how I'm supposed to, okay? This fibrotic valve thickening that can happen the longer that someone is using it. So that's why you can also see that this medication overuse headache is at that 8 days. We've dropped it quite a bit. And then big proponent of where you are likely to see that medication overuse headache. So not our favorite drug. We don't love ergotamines, okay? Contraindications, because I talked to you about that fibrotic valve thickening. You see that I'm not going to use this in my patients who have any type of coronary peripheral type of artery disease. So I just kind of lumped it all in there together. With our triptans, we could potentially do it, but I had to have their first dose be where? In the clinic. They don't have to go to the hospital, but as long as you have monitoring capabilities, we just need to make sure that we're monitoring them, okay? And then because of our elimination of these meds and us fearing the vasoconstriction or the ergotism that could occur if it does build up, that's why you see that we're avoiding this in our patients who have hepatic or renal impairment. And of course, we're, again, not giving it to our pregnant patients, especially. Our drug interactions, we saw this on our triptan slide, now we're seeing it on our ergotamine side. Don't use it within 24 hours of us using a triptan. Looking at our CYP inhibitors, we saw this also on our triptan side. So now this is kind of starting to repeat itself when we're looking at our drug interactions, okay? Dihydroergotamine, so we were like, okay, ergotamine, you're trash, I want to make something that's less trash. So we made dihydroergotamine, okay? It's very similar to our ergotamine, but it has less of that alpha adrenergic vasoconstriction that we were seeing. So you can still get ergotism when we're talking about our dihydroergotamine, but at a lesser extent, if that makes sense, okay? So this is like the 2.0 ergotamine. Looking at this, again, your PK parameters, we have different formulations that you have. So you have your nasal spray and your IM and your sub-Q formulations that are available. When you're looking at your nasal spray, you see that it's not as effective as our IM or sub-Q. And if you think about it, right, I'm having to inhale something. Typically, we'll put them on the same playing field, but the PK parameters of this med make it to where your nasal is not as effective as if you were to just inject directly into your bloodstream. So there you see your DHE 45 that you have, similar to our sub-Q of our sumatriptan, but again, the side effect profile for this is not great. So if we can have our patient tolerate sumatriptan, we're always going to go to our triptans before we hit any of these ergotamines, dihydroergotamine. Triptans are always going to be first. When we're looking at our, and then this you also see here, which is when we talked about this, I think it was last semester, we saw some of our ergotamines and we talked about it a little bit. But this is also, you see that you can see it in your status migrainosis, or a patient who you have tried everything else to get them out of that active migraine that they're having. Because remember, we're in acute, we're in abortive. They're actively having a migraine and they've been in there for longer than our 72 hours, then that's when we can say, okay, like I'm going to give you this medication because they've been in pain for that long. Most of the time, this patient is presenting to the ER. By the time they get their appointment with you, you're not going to see this. So this would be in like one of those ER settings. Looking at our administration, again, we talked about us giving it with the antiemetic because we are likely to see that nausea and vomiting occur. We're not giving this as monotherapy. You see that your DHE over your ergotamine, you're going to see less side effects. So we made, again, remember this as your 2.0 of your ergotamine, less ergotism, which is the big side effect that we're worried about. Now, instead of our 8 days that we have with our ergotamine, now we have 10 days, okay, for our medication overuse headache. Adverse effects, very similar to what we saw on our ergotamine side. But we have less of that ergotism, so less of that vasoconstriction, less of that nausea and vomiting, but we are still pre-treating them for that nausea and vomiting prior to giving it. Your valve thickening is still here, that medication overuse is still here, but because we have that intranasal option, that's why you see that you can have those taste disturbances occur, because anything that I put up my nose, remember, we're all connected. So a lot of the times that's why you'll see where they will tell you that their taste is a little off from them using the nasal. And that's with almost all of your nasal sprays, if you have anything. Your contraindications, looking like we kind of combined what we had with our triptans, kind of with what we already saw with our ergotamine. So you see your uncontrolled hypertension, any of your cardiac stuff, any of your coronary artery disease, any of that is all listed there, your peripheral vascular disease. So just think of this as, if it messes with your heart, if it messes with your arteries, I can't do it when I'm talking about my ergotamine or my dihydroergotamine because I have ergotism. The hepatic and renal function still there, and then your pregnancy still listed as well. And then your interactions are exactly the same with the 24 hours when we're talking about our triptans or any other ergotamines and our inhibitors. I will leave these up here because, I'm going to try that. So our medications that should not be given within 24 hours of a triptan, what do we have? And I use my max dose, right? So 2 and 3, okay? Mr. Williams had his Imitrex, he took one at 8. When is the next time that he can safely take another dose and it's not an injection? Same, right? So remember your 1 hour, remember your 4 hours, and then remember everything else falls in between, okay? Because there's only one for each of those, and then everything else is in the middle. All right, here are some other agents that we have that are available for us to treat our migraine, but we don't use them as much anymore as we used to. So you have your butorphanol or your Stadol, which is a controlled medication. We typically, when we're talking about migraines and we give this, it is nasally. So it comes in this big plastic container that we will dispense. Haven't seen this used as much anymore because now most of the time when we talk about Stadol, we use it for pain. But you see that we have it's a mu agonist, partial mu agonist, and then you have your kappa agonistic activity as well. So again, just make sure that you're understanding that this is typically when we're using this pain medication, We have several different formulations of it. We can use it for our migraines, and this is the picture. Oh, there. This is a picture of what it looks like whenever we're giving them the one for the migraine. Last resort, not fantastic. Our other uses that you have, pain management and during labor. So I tried to have my first child naturally, personal story. And I was like, oh, I don't want an epidural. I just want to have my kid. So I was in there for 3 days, just trying and trying. And they're like, you need to sleep. And I was like, no, I need to get this baby out. And so they were like, well, let's give you something that will also help you with sleep, but like a little bit with pain. I was like, I don't want pain meds. And they tried to convince me that it wasn't pain meds. And I was like, all right, I'm sure they're sick of me and they just want me to go to sleep. So I'm going to take the meds. I woke up and I told my husband before we went to the hospital, I'm not going to be dramatic in the hospital, I promise. So if I tell you something, I'm being serious. So I woke up and I looked at him and I said, is this real? And he said, what? And I said, I'm on fire. This is real. And he was like, well, you're not on fire. And I was like, I'm burning. So what happened was my pain receptors got activated with Stadol instead of relieving my pain, and I felt like I was burning. And I don't know if he was a PA or the doctor, but I was mad at him either way. He came in and he's like, yes, how can I help you? And I was like, I'm on fire. Like, I said, the only med that y'all have given me at this point that could have done this was the Stadol. And he's like, well, I don't see a rash. I was like, I don't care what you see, I need some medicine, okay? So make sure when you talk about like things that are hitting our pain receptors, our those mu receptors, those kappa receptors, you can also get where sometimes it can trigger like that pain type of reaction in your patients. They ended up giving me Benadryl, which didn't work, and I just had to wait for the medication to wear off. But I told my husband, I was like, I'm dying. Don't do that to your patient. Don't say, oh, I don't see a rash, because it didn't present as a rash. Okay, it presented instead as all of my pain receptors being activated at one time and me feeling like I was on fire. That was the only thing I had for him. So, your caution, psychiatric disturbances, I literally felt like, that's how he was looking at me. My husband was like, you're not on fire. But you can definitely see this, and then what ended up happening, my son's heart rate did drop, and then I ended up having to get an epidural. So you see these abnormal fetal heart rate. That did all of this whole slide happened, okay? So just make sure that you're remembering some of the things that can happen. Your taste perversion, again, typically you're seeing that when we're treating our patients for the migraines because they have the nasal option that way. So just understand, again, very, very, very type of last line, hit or miss on if it works for the migraine or not. And then again, with that nasal formulation, we can have hypotension potentially occur. So just something to watch out for. Some people respond to it. Some people have been prescribed it and they love it for their migraines. And if you have one of those patients, you can try to say, hey, did you ever take a triptan before? Because again, this is a controlled medication. If we can get them off of something that is a controlled medication, that's what we would like to do. So try to retrial them on a triptan if you can. Additive effects, because of that CNS depression that we can see with our butorphanol, we can also see that when we're adding on other opioids and things like that. Antiemetics, we have several antiemetics that we can use. Some of them, when we're talking about our migraines, which can potentially cause nausea and vomiting, we would want to try to counter that with some of our antiemetics. We'll get into this more when we start talking about like different meds that we can use in our pregnant population. But again, just making sure that you kind of remember what we talked about last semester when we were in GI with Colonel Kwan was talking to you guys, right? So you have your different things that you can use. So we have metoclopramide that you have. We have your prochlorperazine, your chlorpromazine, your ondansetron, and your ganacetrin. These are all different options for us to use. When you're seeing your metoclopramide or your Reglan, this is one of the ones that is kind of safer for us to use. We can also try to use this one without a migraine medication to see if it helps, but most of the time it's not going to help with the migraine. Some people will say that they just take this and they get relief from it, so that's why you see this says it can be used alone. EPS side effects, that we can see with this, looking at our typical antipsychotics that we have. You also know that with our antipsychotics, we had EPS side effects. So you're going to see those again here. Several different formulations that we have. When you're looking at your chlorpromazine, make sure that you're understanding that it can cause our QT prolongation. Looking at our serotonin or our 5-H3 antagonist that we have, this one is kind of paradoxical in the sense that it can cause headaches, but we are trying to treat nausea and vomiting in a person who has headaches. Most of the time when we do give our ondansetron is the one that we typically prescribe, you will see that some patients will have resolve of their nausea and vomiting, but we're also giving them their anti-migraine medication, so maybe that's why we don't see as much of as many of these people complaining of the headache, but it could potentially make it worse, okay? So just make sure that you're understanding that that's there, but these are at the bottom. So you're kind of starting from the top and going down with your preference as to which one you're going to be using, okay? Okay, our prophylaxis that we have. So this is now for my patient who you've had so many headaches, right? And we're going to talk about this indication of who gets prophylaxis. And so now I'm saying I'm going to put you on this medication. You're going to be taking these medications every day. There are some that we don't take every day that we'll talk about as well. So if you have had more than 4 headaches in a month, or if you have had more than 8 headache days in a month, then you can get prophylaxis. What this means by the headache days. Headache days is, today is Monday. I have my migraine. And I choose not to take any medication. The pharmacist who hates meds, right? And I don't take anything. I'm like, I'm gonna tough it out. Here's day 2 of my headache, right? And then it goes away. And then on Thursday, I have another headache. And that one lasts for 3 days. Now I'm at 5 headache days in that month, okay? But I really only had 2 headaches. So headache days versus a headache is 2 separate things. So make sure that if you see a question that's talking about it and you're trying to decide if you need to do prophylaxis or not, do I have that 4 or more headaches that I had in that month? Or did I have 8 or more headache days, okay? Headache days is not the same thing as headaches. Want me to repeat it again? I'm getting the face. Okay, I'm getting a lot of face. Okay, so a headache, right? I have 1 headache right now, all right? And let's say this one lasted for 2 days, and then I had another one, and that one lasted, and we're talking about in a month time frame. And I had another one, and that lasted for 3 days, so now I'm at 5 days, okay? I still only had 2 headaches, but I have now 5 headache days, okay? Then I had another one, and that lasted for 4 days, so now I'm at 9 days, right? But I still only had 3 headaches. I can qualify for prophylaxis because now I've had 9 headache days. Even though when you're looking at my headaches, I've only had 3 headaches, okay? So it has to resolve. Even if you gave me my triptan and my triptan didn't work and I still had my headache days, that's still counting for me, okay? For me to end up on prophylaxis, which is typically what we'll see, is that some of our patients will have them on that triptan, but they're having where their headache didn't go away that first day. It lasted for 2 or 3 days. Our triptan isn't as effective anymore. And that's what your patients will typically come back and tell you, oh, my meds aren't working anymore. Okay, so we have our first line agents that are in the box. These are the ones that I'm wanting you to focus on, okay? When you're looking at this, you're going to put them on one of these first line medications, and then you're going to titrate it every 2 to 4 weeks to get them to that maximum dose that they should be on. If you have them on a lower dose and they are tolerating that and that is helping resolve their headache, then great. If it is not, then you wait at least 2 to 4 weeks before you increase their dose, okay? So they're going to need some time before you increase their dose. Don't be like, here you go, Raina, and put me on the max dose automatically. Because that very small dose could be all I needed to help. All right? And you need to save that max dose because what happens when I come back and I'm like, all right, doc, now this dose that you gave me, it's not working anymore. You're not going to have any room to now titrate me up further. Okay? So start low, and then start to build me up. If I'm telling you that I'm failing, then that's whenever you can start to increase my dose, but no sooner than that, 2 to 4 weeks. And then let's say I come back and you had me on that max dose, and I've been on that max dose for like a month or two, and it's not working. Now you can say, all right, maybe I need to switch you to another first-line medication, switch you to another triptan to see if you have a response to that. Okay? So that's when you start to change it. So you're titrating me every 2 to 4 weeks, but I have to trial the medication and make sure it works for at least 1 to 2 months before you can just switch me to something else. If I've only been on it for 2 weeks, you're not automatically going to change me. You're like, give me a second, let me try to work with the meds, let me try to titrate you up. We still have room to play with this one agent before we start knocking off other things. Okay? So you see that we have several different options prophylactically for my migraines. Remember, this is prophylaxis. This is not my abortive, so I'm not in acute. Okay? I have amitriptyline, my valproex or my valproic acid, so my Depakote, my propranolol that I can use, my topiramate, and then I have my calcium channel blockers that I have, so my candesartan, some telmisartan, and then I have some CGRPs that are also available, okay? So these are our medications that patient would be taking to try to prevent them from having headaches because they either had more than or 4 or more headaches in the month or more than 8 or more headache days in a month, okay? And then this, I don't need you to worry about going down here, but this is like saying, hey, nothing else works. These are other options that you'll hear people say. There's different herbals and all that stuff. I'm worried about what's in the box. These are our options that we have for prophylaxis. Okay? Yes?
Those like an order of merit or no offense?
No, because some people may respond to one and not the other, and you might have to kind of play around with what they respond to. Okay? So that's why we were saying, when you're titrating them, get them to that maximum dose that we have for prophylaxis, and then you may have to switch them to another one because it didn't work. Okay? I'm still having my migraines. So when you're looking at this is already what we talked about, when we're going to put someone on prophylaxis. We already talked about our days, so it's on the other side if you want more. It's on this side right here, but if you want more details, then you can continue to read this. FYI, this side is what I'm saying, okay? Because it's already on the other side. Right? When we talk about our menstrual migraines, we'll talk about those specifically, and we had some of our medications that we were using. Again, that could be prophylaxis. I know when my menstrual cycle is going to start, therefore I can start taking my medication for my migraine at that time. Looking at some of our other considerations, we already kind of went over this as well. Make sure that you're not titrating more than that 2 to 4 weeks. So I'm going to put them on a dose, and then I'm going to try to get them to that maximum dose before I just say, hey, this agent is a failure for them, right? All right, Raina, you don't tolerate propranolol well, so I'm going to exit. Don't do that if you haven't gotten me to that maximum dose of propranolol. And while you're trying to titrate me up to that maximum dose, if I start to have adverse effects, then we're also cautious of that, right? So when we say our maximum dose, yes, we have a number that when you look that up on LexiDrug, it's going to tell you. But we also have to look at my symptoms and how am I tolerating it, okay? So the maximum dose that I can also tolerate. And then looking at this, effectiveness, tolerability, and their comorbidities, sometimes we can pick a prophylactic drug that also has a benefit for some other comorbidities that they may have. Oh, I also have seizures. Maybe there's something that I can use for that. Oh, I also have depression. Oh, I also have high blood pressure. There's several different things where we can kind of kill 2 birds with 1 stone, put them on 1 medication, okay? The doses may be different, and we would typically go with whatever that higher dose is to treat that other disease state. And then hopefully we'll also see some relief from the migraine. If not, then that means that we have to add on another agent for that patient. Could take up to 6 months for our patient to see our full benefit. Although you will see where sometimes we'll give them that 1 to 2 month trial period. Make sure that if they're saying, like, if let's say we were starting and I told you I was having, 6 headaches in a month, and now you're like, oh, well, we got you down to 5 or 3. Like, maybe it is working. Give it some more time. You don't necessarily have to automatically like switch. But if I said, I'm sick of this, I want none, You can say, okay, I can try you on another med. Is that realistic to go from 6 to 0? Most of the time, no, they're gonna still have some happen every now and then. So, up to 6 months for us to see that full benefit, but typically we're wanting that 1 to 2 months for us to have an adequate trial period. And how often are we titrating? 2 to 4 weeks. So 2 to 4 weeks of titration, 1 to 2 months for the trial period, up to 6 months to see what the medication is actually going to do for them to decrease those migraines. You also see here, so let's say I get to that 6 months and I have a headache-free, no migraines at all, period. Okay, so 6 to 12 months. Then you can start to say, I'm going to gradually taper them off. Just like I said, I had to taper them up, I can taper them off with some of these medications. So let's say I start to taper them off of their medication and discontinue their therapy. I didn't leave them on it forever. But if they start to have those migraines again, or while you're tapering, they start to have the migraines again, then put them back on their doses and know that you can't taper them off, okay? Anytime you do a taper, that's most of the time how we're gonna do that. You start to see symptoms, whether we're tapering them off to discontinue a medication, or tapering them off because you're worried about addiction and we want to prevent withdrawal. You can always start to taper, and when you start to see symptoms or that disease occur again, you can put them back on and then slow your taper down, okay? So, looking at this, these are our different medications, again, that you saw on the other side. This is now breaking it down in more detail of what is considered your first line versus what are considered some of your second line options. So you'll see, for instance, with our beta blockers, we have ones that we prefer. We prefer to use our propranolol versus looking at our nadolol, right? Our nadolol is more of a second line type of thing. So just make sure that you're looking at the difference between these two and saying, all right, what is considered my first line therapy for me to prevent this from happening to my patient versus my second line. When you're looking down here at the bottom, this is just giving you the fact that, like, hey, if I had a comorbidity, I could use this medication, right? So if I have somebody who has hypertension or some type of ischemic heart disease, a previous MI patient, what have you, I can also prophylactically have them on one of my beta blockers, right, for their migraines. And then if I gave you 2 beta blockers and you had to pick one, always pick your first line over picking your second line. Okay, we always start with first line over a second line. Okay. Same thing when we're talking about our amitriptyline. This is something where we had a patient who was like, oh, you know, I can't sleep very well, or I'm depressed. Amitriptyline is a good option. Your venlafaxine we can also use for our patients who have depression, but remember that you're also seeing your venlafaxine as one of your second line ones, and your valproex that you see, good for your patients who may have bipolar or seizure disorders. So again, all of these are first line except for your venlafaxine, but then these are like conditions that you can see where you can treat 2 things with 1 medication, okay? And that's what we like to see, because we're decreasing the pill burden on that patient, we're increasing their adherence that they're gonna have for us. And then last slide that we're going to look at, y'all have seen some of this, well actually y'all have seen all of these before. So you have your beta blockers, your anticonvulsants, and your antidepressants. Just remember what your side effects are for if you were using a beta blocker, right? So the things that we always say, like watch out for our patients who have asthma, watch out for our patients who have bradycardia, looking at our adverse effects, those are things that can happen. Our beta blocker blues, right? So them getting depression because they're taking a beta blocker. The sexual side effects that we talked about, the tiredness, all of these things are the things that we already talked about when we're talking about beta blockers. Your anticonvulsants, just look over these, make sure that you're skimming them for the most part. Fatigue, different small little minor things that we'll see whenever we're talking about this. Weight gain, depending on what class our anticonvulsant is in, especially when we're talking about our valproex, you'll see that a lot in. And then your antidepressants, making sure again that you're looking at, hey, what are the different types of side effects that we talked about that are grouped here. I won't go back to your slides from last semester. I will look at specifically the adverse effects from this slide deck. So that's why you only see the drug class and then you see the adverse effects in red in our contraindications. Okay, and then we'll start here tomorrow.